Hi and welcome back to yet another session with Conceptual OBG. Today I'm going to be talking in this brief reel a topic that is very important. Important is an understatement honestly because I am pretty sure that every third or fourth patient that you have in your clinic or in your hospital is going to have preeclampsia. To be very specific, the prevalence in India is 1 in 10 to 1 in 20. So technically every fifth or every 10th patient definitely has preeclampsia. The sad part about this is that despite so many years of preeclampsia and India being a hotspot for preeclampsia, genetically predisposed to preeclampsia and eclampsia and its adverse side effects, or not side effects, complications like eclampsia, have we still reached a point wherein we can effectively predict and prevent or at least delay the onset of preeclampsia? Let's discuss it in this video. So first of all, preeclampsia is the definition, of course, as William says, a rise in blood pressure over systolic being more than 140 or diastolic being more than 90, 2 occasions apart, 4 hours apart. So that's a basic definition. But this session is going to be about how to predict it. Now, why does preeclampsia occur? Of course, you all know faulty trophoblastic invasion, the spiral arterioles. They have to, the tunica intima and the tunica media has to be destroyed, and the extravillous trophoblasts have to come there and settle there. Now, because of this, the high resistance spiral arterioles become low resistance vessels, so that the blood supply to the placenta and eventually to the fetus is increased. Of course, pregnancy will need more blood to the uterus, and by uterus I mean to say the fetus and the placenta. Now, when this trophoblastic invasion is going to have some problem in it, the blood flow to the placenta and the fetus is going to be reduced, and this will create a state of hypoxia. This state of hypoxia is going to increase the anti-angiogenic factors, the two commonest ones being soluble FMS-like tyrosine kinase and soluble endoglyne. These two factors are going to destroy the good factors, that are the pro-angiogenic factors, which happen to be placental growth factor and vascular endothelial growth factor, VEGF. Now over here we have two factors that are going to help me predict. The lesser the progenic or pro-angiogenic factors and the higher the anti-angiogenic factors, the risk of preeclampsia increases obviously. So one of these factors, the pro-angiogenic factor, happens to be my placental growth factor. So if the placental growth factor's level is more than 100, then the risk of preeclampsia occurring is very low, because obviously the higher the level of a pro-angiogenic hormone or a enzyme or any whatever I'll call it, lesser the risk of preeclampsia, whereas a level below 33 is going to indicate a very high risk of preeclampsia later on in pregnancy. Similarly, there's a ratio. In that ratio, I am going to have SFLT, that is my soluble FMS-like tyrosine kinase, divided by placental growth factor. Now, till 34 weeks of gestation, if this ratio is checked and if it is more than 85, then there is a very high risk that you're going to have some adverse event. It can be severe preeclampsia, it can be eclampsia, it can even be abruption in the next 1 to 2 weeks. Before 34 weeks if the levels are more than 85, whereas after 34 and before 37, that period of 3 weeks, if the levels are more than 110, the ratio of SFLT by PlGF, if the levels are more than 110, then there is again a risk of a severe event or a very critical event of preeclampsia in the next 1 to 2 weeks. Why is this happening and why are these two different thresholds? Remember that in your third trimester, the PlGF levels increase initially, and near term the SFLT levels increase initially or on the later stages of your third trimester, which is why these two differing values for prediction. Is it worth doing? I don't know. I do not know whether it is worth doing, because the cost doesn't justify doing it yet. The only advantage that I can offer to a patient who is, let's say, 25 weeks, 30 weeks, by doing this test is I can tell them whether they will require a delivery in the next couple of weeks, so that I can give them steroid cover or magnesium sulfate for neuroprotection below 32 weeks, and maybe I can just admit them to the ward and keep them in the ward to monitor them. But I can't do nothing to delay this. All I can do is I can just take precautions to ensure that the maternal morbidity, the fetal morbidity is reduced to some extent. So is there anything wherein I can actually make a difference? Yes. In the late first trimester, there are a few tests that we can do to predict. The first and the most important is the uterine artery Doppler. Uterine artery Doppler has to be done alongside your NT-NB scan, and of course, if your spiral arterioles have low resistance because of good trophoblastic invasion, then in that scenario you will have less resistance, and less resistance is going to reflect as less RI, that is resistance index. Another way of looking at resistance is also PI, that is pulsatility index. So uterine artery pulsatility index, when it is on the lower side, that's a good thing because it indicates that there is low resistance to blood flow, and that's a good thing. But if it is high, and by high I intend to say between 11 to 14 weeks, if it is more than 2.4, the mean, the average of both right and left uterine arteries, and at 20 to 24 weeks of gestation, if it is more than 1.4, so 2.4 and 1.4, if it is more than that, then the risk of preeclampsia and fetal growth restriction is pretty high. But I said that I can do something about it. So what it is, so if I'm able to do this in the NT-NB scan, to do this uterine artery PI, and I'm able to know that the uterine artery PI, the mean PI is more than 2.4, then I can initiate the patient on aspirin. Aspirin, when initiated, low dose aspirin, the ideal dose is 81, but we don't get 81 in India, so you can either start 75 or 150. I prefer 150. Then you can at least delay or reduce the intensity of preeclampsia, but the catch here is you have to start it before 16 weeks, because by 16 weeks the trophoblastic invasion is complete. So that is one more thing. Apart from that, is there anything else that I can do? Of course, we get extended first trimester, combined first trimester screening. In that extended screening, we also check for PlGF levels, as I've already discussed, and I combine it with uterine artery PI. One more thing that I can do is I can look at the mean arterial pressure of a patient. So if the mean arterial pressure is more than 90, the MAP is more than 90, then it is going to be suggestive of future risk of preeclampsia. Apart from that, a few other things like the past history of that female, the medical history if the patient has something like chronic kidney disease, any SLE like autoimmune disorder, or diabetes, overt diabetes mellitus, or history of preeclampsia, abruption, severe preeclampsia, unknown stillbirth in previous pregnancy. All these risk factors are again going to tell me that this patient now in this current pregnancy needs a little more vigilant and surveillance that will cater to both the mother and fetus. And of course, they are also going to be the candidates for starting on aspirin right from the first trimester. Apart from that, what does future hold for me? In future, we do have a few biomarkers, a few tests that are in studies. The names include placental protein 13, ADAM12, and soluble endoglin levels, microRNAs. There are all these things that are in the works that maybe at some point will help me predict better. But again, by predicting, all I can do is I can intensify the surveillance. So what should we be looking up to? We should be looking up to a few drugs that will reduce the possibility of a female getting preeclampsia, or at least delaying it. Right now we have aspirin, it is not that effective, but we can do better. There are a few drugs like sildenafil, not proven effects, HMG co-inhibitors, the statins, metformin. There are so many drugs that are still under studies that they say may have an effect a few years down the line. I believe that statins are going to be given in pregnancy. They are going to be safe in pregnancy, rosuvastatin, atorvastatin, because they prevent or delay preeclampsia. There are many such things that I believe will happen, which will take some time, but we have to look forward to it, and our focus should be not just predicting but even preventing preeclampsia in the future. So that's it from Dr. Aditya in this session. I hope you all liked this Predictors of Preeclampsia reel, and if you have any suggestions for what should I be talking on in this brief reels, comment and I'll make a video on that. Keep watching Conceptual. Dr. Aditya signs off.